and then it comes down, and then back to documentation, just to emphasize, you document, you document, you document, you write down everything. Stop. These little dots here, this is the systolic pressure. Actually that's the heart rate there. He's going to be putting in the diastolic pressure down here. These are coming in every 5 minutes. So every 5 minutes he's writing this down. What was happening during the procedure? This is a responsibility to the patient. This is also part of good care, so if there's a trend, he can see it in his own document. Please continue. Now, let's look at some complications here. Hypotension, please stop. The blood pressure has dropped to 86/38. So the patient's blood pressure is low. How often do we see this in the operating room? All the time. Every day. Propofol lowers blood pressure. And when patients come in and they're a little bit dehydrated because they haven't had anything to eat or drink, and by dehydrated I mean they haven't had saline. They haven't had water or juice or whatever they would have in the morning. When patients come in, they're a little dehydrated, and they get propofol, we see the blood pressure drop all the time. It's no big deal. So he sees the low blood pressure here. Please continue. So there's several ways of addressing this. First, you might give some more saline, but here he's drawing up a drug called ephedrine. Ephedrine is a drug that's simply going to raise the blood pressure a little bit. Please stop. Now, what is this? That's the IV line. Remember, I mentioned the IV is a way of constantly getting drugs, any drug, into the patient quickly. So he pushes this into the IV line, and then this, along with the saline, it flows right into the patient. And as it flows into the patient, it flows into the bloodstream where it works. So he's pushing it into the IV line here. Please continue. Please also notice that this drug was immediately available, and with that, the blood pressure comes back up to 104. Now, stop, let's go a little bit further, and stop here. This is the carbon dioxide. This represents when the patient is exhaling, and there's carbon dioxide seen at the sensor, and then this is the patient inhales, patient exhales, patient inhales, and so on. Wraps around to here. But right here, patient now exhales, and then the carbon dioxide stops. What happened to the carbon dioxide? The airway is obstructed. And when you have this monitor on the patient, you can see that the airway is obstructed immediately. So the airway is obstructed here, and within a matter of seconds, it's clear to the anesthesiologist that the airway is obstructed. Please continue. So this shows up here, obstructed airway. So what happens here is something called chin lift. And just please proceed. And then stop right there. If you pick the chin up and move it like this, so you just pick the chin up and move it forward with your thumb pulling out a little bit, that will almost always open the airway. Anesthesiologists do this routinely. Anesthesiologists do this without even thinking about it. We do it and we don't even change this topic of conversation, because if the person's tongue has fallen back a little bit and the airway is obstructed, you just reach over and you just pick up the chin. And when you do that, most commonly, the tongue is now out of the way and the patient is breathing on their own. Usually that's all that's necessary. It's an absolute reflex that is taught to really, I think, almost all physicians. Let me say all physicians. All physicians understand this simple maneuver to open a patient's airway. You just pick the chin up. Please continue. And with that, you can see the patient starts to breathe. This is called the jaw thrust. If that, you basically want, stop, and this is the mandible right here. You want the mandible to move forward. When the mandible moves forward, it takes the tongue with it. And by taking the tongue with it, it gets the tongue out of the way. So if the chin lift doesn't work, you actually grab the entire mandible, shown here, and push it forward. And that moves the tongue off the back of the throat. Again, this is something that physicians learn in medical school. And it's an expectation. Every physician recognizes airway obstruction and knows these simple maneuvers to open an airway. Next. And now you can see the patient is, again, breathing here. If you need to, you can put in this oral airway or this nasal airway. If those fail, then you put in something to move the tongue out of the way, and you turn up the oxygen so the patient is receiving additional oxygen as well. Okay, now, stop. You keep doing this until the patient starts to breathe. You don't just do it once, because you're responsible for seeing that air is constantly moving in and out of the patient's lungs. So you do this until you verify that the breathing is okay. Please continue. Now it's still obstructed back here. But finally here, what we'll see is normal breathing is now seen, the obstruction is gone, and the patient is again moving air properly. Please, you are continuing. Okay, apnea, please stop. Apnea is a prolonged period of no breathing, and it usually means there's no respiratory effort. In apnea, the patient is not obstructed, they're just not trying. They've received enough drug that they're not even trying to breathe. So apnea means they're just lying there, not breathing. In that case, you have to take over, and you have to force the air in and out of the lungs of the patient. So if we can move to that. So you see no carbon dioxide. He takes off the nasal prongs. Why? He needs to make a seal with the mask, and the tubing interferes with it. So the mask is applied to the face of the patient, the bag is squeezed, and as he squeezes the bag, he forces air into the lungs of the patient. Stop. This is our fail-safe. Patient's not breathing. You open the airway. Patient's no air is still moving. This is our fail-safe to put air into the lungs of the patient. If they won't do it, we will do it for the patient. Please continue. So we can force the oxygen into the patient's lungs if the patient is not breathing. Aspiration, please stop. So this is just a point where if the patient starts to retch and then vomits a little bit into the throat or has a little bit, sometimes you call it acid aspiration. The head of the patient is turned sideways so that the vomitus flows out of the mouth. After you turn the head sideways, you immediately grab your suction. And as I said, by immediately, we mean before the next breath. And you put it in and you suction out the patient's mouth so that there's no chance of stomach contents being inhaled into the lungs. This is critically important. And when an anesthesiologist sees that a patient has a little bit of vomitus in the back of the throat, they respond in no more than 1 second, because this has to be dealt with emergently before that goes into the lungs. Yes. Cardiac arrest. So now we're going to talk about what happens in the event of an actual arrest. Please stop. Here, what you'll see is that the heart is no longer beating. This used to show an electrocardiogram pattern, but now it's gone flat. The heart has stopped beating. The patient is not breathing. This is a cardiac arrest. Again, you have to respond instantly. And I cannot emphasize enough the first response to an emergency. Please continue. So he first, stop. Is the monitor correct? Or did the leads just all fall off? So he just, please continue. Just wants to check that the patient has in fact had an arrest. Stop. Calls for help. Those of you who have taken CPR course may remember the instructions for CPR. You find a person who is unresponsive. What's the first thing you do? Call for help. When you take advanced cardiac life support, what's the first thing that people are taught to do? Call for help. When you are an anesthesiologist, in your very first days of training, probably your very first day of training, if there is a problem, what do? You call for help. Before you treat, when it's an emergency, you call for help because you're going to need it, and you're going to need it now. So the very first thing that Dr. Hung does here is he calls for help. Fortunately, his children are actually in the room ready to respond, if you can continue. So he calls for help. He immediately, one person begins CPR, the chest compression shown here. Dr. Hung is now ventilating the lungs, shown here. And emergency drugs are drawn up for resuscitation. This right here is lidocaine, which might be given for resuscitation. Other drugs that might be given for resuscitation include drugs like adrenaline. So please stop. So in an arrest, in an emergency, you assess the patient just to be sure that the monitor has not failed. That takes maybe 3 seconds. Then the first thing you say, the first thing you do is you call for help, always. Then the person's heart is not beating, you start chest compressions, you ventilate the lungs with oxygen. This will keep the patient alive. This will keep the patient alive long enough, hopefully, to fix the problem, to fix the reason for the arrest. This may involve giving drugs to raise the blood pressure. This may involve giving blood if the person has, for example, a gunshot wound or something like this. It may involve using electrical energy to start the heart again. But you use these steps to keep the patient alive, but they're only used to keep the patient alive while you institute what actually reverses the arrest and restores the patient to breathing on their own and having the heart beating on its own. Please continue. So you continue the CPR and the advanced cardiac life support until one of two things happens. Either the patient revives or the patient is pronounced dead.
Thank you.
Thank you.
Good time, Your Honor.
Yes. It's 1 minute before noon, ladies and gentlemen. So we are going to take the noon recess at this time. Of course, please continue to observe to the letter all of the admonitions. Please enjoy lunch. We'll be in recess till 1:30 this afternoon, at which time we'll resume. And thanks again for your patience. And Dr. Schafer, after the jurors leave, you may step down as well, remembering the admonitions, and please come back at 1:30.